Hello everyone and welcome to the third webinar from the Society for Implementation Science in Nutrition. This webinar will focus on understanding program adaptation. My name is Wendy Gonzalez. I'm a technical specialist in knowledge leadership at the Global Alliance for Improved Nutrition, GAIN. I'm delighted to be moderating today's webinar. Just a little housekeeping before we get started. If you have any questions during the presentation, please type them into the question box in your GoToWebinar control panel. You may send in your questions at any time during the presentation. We will have a Q&A session at the end of the presentation, and I will pose as many of your questions as possible to our speaker at the time as the time allows. If you experience any technical issues, please also type your question into the question box. Our staff will help you address this. We're also active on Twitter and encourage you to chat and engage with us through our Twitter hashtag, which will appear on the chat box. Finally, a PDF of the slides and recording of the webinar will be added to the website in due course. It's a pleasure to introduce today's guest speaker, Dr. Cam Escoffery, whose presentation is entitled Understanding Program Adaptation, a scoping study of frameworks and systematic review of adapted evidence-based interventions. Dr. Cam Escoffery is an Associate Professor of Behavioral Science and Health Education at the Rollins School of Public Health, Emory University. Dr. Escoffery is a health educator and behavioral scientist by training. She has a PhD in health promotion and behavior with an emphasis in instructional technology. She has conducted research for over 23 years on health promotion, cancer prevention and control, health technology, implementation science, and evaluation. She has served as PI on grant funded by the National Cancer Institute, Centers for Disease Control and Prevention, American Cancer Society, and Healthcare Georgia Foundation. She has published widely on various topics in health promotion, dissemination and implementation science, and cancer control research. She enjoys teaching community engaged and health promotion skills-oriented courses. Cam, the floor is yours.
Thank you very much. I'm delighted to be a guest for the Society and talking about some of my research and work in understanding program adaptation. This is an overview of the presentation today. On the agenda, I will be defining and giving the rationale for why we want to focus on program adaptation in translating evidence-based interventions. I'm going to present research on two studies, scoping studies of adaptation frameworks, and then present some findings that we have from a systematic review of public health evidence-based program adaptations. And finally, focusing on some future research in advancing adaptation from our work. These are the learning objectives for the presentation. We hope that you will take from this presentation being able to describe or define program adaptation, identify some frameworks that might be relevant to your work for adaptation processes, and what are some common steps that you can engage in an adaptation process. And then understanding what people are doing in the field in terms of reasons for adaptations and the types of adaptations that they actually conduct. In terms of your classification schema and the focus of some of your work, the presentation today probably will be most pertinent to nutrition-specific interventions because program adaptations are often made within the scope of package programs. And we can have other discussions about that at the end. I wanted to start off with a framework for implementation science or translation. This framework is familiar to many of you who are interested in bringing programs to scale. So a lot of times we start off in the early steps in conducting efficacy studies where we're trying to figure out what strategies or interventions could work in terms of making a public health impact. Then we move on to efficacy studies, which we try to have outcomes that are evidence that a program does work. And then with that knowledge, we want to take them to scale. So making the program work in a lot of different practice settings. And in the yellow box, you can kind of see that in terms of scaling up interventions, you have a phase of exploring options or interventions that are out there, adoption of the intervention, implementing it, and hopefully if you have some early positive effects, you're thinking about maintaining the program. I just made a slight change to this in that sometimes we don't just adopt a program as is. Sometimes we actually make program adaptations before implementation, and that's the focus of the webinar today. So I wanted to start off with the first objective in defining program adaptation. There are two definitions here. Program adaptation is a degree in intervention. It's change by your public health staff to be able to understand its implementation in an adaptation process. The second one is using basically the premise of getting an effective program and looking at its components in trying to fit the needs of a new population or context, and the idea that you want to maintain the core elements of the original program. And core elements are often defined as the elements that make the program effective. It could be based on theory, it could be based on your evaluation or your research. And on the right-hand side, I did kind of put 4 basic dimensions of adaptations from a lot of definitions and some of our work. You will see a lot of definitions talk about changes to elements of programs. A lot of definitions also talk about the fit of the original program to your new context, whether that be a population, a setting, a community, or a type of organization in terms of changes. Some definitions focus on the concept of fidelity, as I mentioned, being true to the original program. And then a few definitions also talk about being more planned in your adaptation. And we know that sometimes that always doesn't happen, but a systematic adaptation, much more is proactive in most cases. So why do we want to focus on program adaptation? Well, we want to be able to send what works in the community, some of our evidence-based practices, to other settings. So that's probably the number one reasons. We also know that adaptations are occurring in practice. A couple of systematic reviews that I've highlighted here have shown that people are making changes to evidence-based interventions as they're implementing them to meet the needs of the population, and that there are varying levels of compliance or fidelity to interventions that have been implemented in hundreds of settings that have been studied. And in terms of some of my work in building capacities for health professionals in using evidence-based programs, I often see that professionals know how to find evidence-based strategies or interventions. They might know how to evaluate, but they have a less understanding of skills or the kind of concepts needed for program adaptation. In terms of different types of adaptations, sometimes you see that people are deleting or adding elements to programs. Sometimes they are changing aspects of delivery or implementation. So sometimes it may be making changes to the curriculum. And other times there are more specific changes based on the culture of populations. And we know that that's very important, particularly for many of you who are working in global settings. Taking a program from one country to another country, you have a lot of not only setting differences, but culture and populations and context differences, perhaps. On the right-hand side, if you're interested in types of adaptation, we've been using this taxonomy of adaptation developed by Shannon Sturman, and it has 5 basic areas of changes that people commonly make. Content changes to the materials, context changes. Also, you have delivery or mode changes, training, and evaluation in terms of getting your program evaluation measured in different ways. So now I want to take you through two studies that kind of advances our understanding of program adaptation. The first one will be a scoping study of adaptation frameworks, and the second one is a systematic review of adapted interventions. So first, the scoping study and some of our work was trying to develop capacity for program adaptation. We wanted to kind of see what guidance was out there. And so this study basically answers two questions. What are the published studies and or reports that are available and describe program adaptation? And the second one, more importantly, helping us to understand the adaptation process, what adaptation steps are found across these different guidance documents. So what we did was we looked at Google Scholar in terms of some gray literature or published reports. We also looked at published literature through some of these bibliographical databases made in Point 2, PubMed, PsycInfo, and so on. And we also reviewed the reference list of articles that we found for additional frameworks. We then coded the frameworks that we found and grouped their steps into the common steps, and then are sharing the compile steps. And it's applying a scoping study framework that you can kind of see developed by Arsky and O'Malley, where you identify your research questions, identify your frameworks, select the relevant frameworks based on your inclusion criteria, chart and summarize the data. And because many of us are working in the area of translation of evidence-based interventions, we can consult with each other to kind of ensure that we have defined the right steps. So these are the 13 adaptation frameworks that we have found. 3 were in the gray literature, and you can see those on the left side, including Center for Substance Abuse and Prevention's guidelines for balancing program fidelity and adaptation, all the way to intervention mapping. And on the right-hand side, you'll see articles and frameworks in the more published literature. I won't go over these specifically. You have an attached handout that actually describes these frameworks in a little bit more detail and actually indicates in a matrix which adaptation steps that they have. And the article also has the references, so that's there for you to look at. But we more wanted to kind of share the global findings from this work. So across those 13 frameworks, we were able to identify 11 common steps. And I'll just go over these fairly quickly, but I also have an attachment at the end that if you have more specific questions, I can go through as well. So in the adaptation process and in any public health planning process, we often understand our community. It's very important for adaptation because you want to look at the intervention that you're considering, which is number 2, and understanding how it would fit or match your community. So having a good understanding of your community, their psychographics, some of the determinants for that health issue are all very important in choosing or selecting the evidence-based intervention, which is step 3. Step 4 and 5 also are typical things that we do in public health in terms of stakeholder engagement. But these are, I think, critical in terms of adaptation. So consulting with experts means that you're talking to experts who might know the topical area, who might know your audience or your context, who are community gatekeepers for implementation. And all of these different stakeholders can kind of give you advice on making changes or making necessary changes to the adapted interventions, but also telling you where you might be making changes that will kind of harm your implementation in terms of maybe not being true to the core elements. Consulting with stakeholders is also important in terms of, again, these are relevant experts to kind of give you information and expertise to make those suggested adaptation. I would say that deciding what needs to be adapted should be critical, and you might want to think about who's involved around the table in terms of the adaptation review of suggested changes or needed changes, and then why the changes are being made, and understanding the core elements. So making sure that process is done. Then you go through the period of making changes to the original program and whatever types of adaptation that you are making. You want to train the staff on the new adapted intervention. You want to test the adapted materials or actually pilot the full interventions. This can kind of go through smaller testing of adapted curricula or brochures or activities to the full scale kind of a pilot intervention, so that you can actually understand delivery and make small revisions along the way. Then you actually want to implement the adapted interventions and evaluate. In terms of the steps that were more common, I've actually highlighted them in pink here. 8 of these steps were described in these 5 frameworks a little bit more consistently, and you'll see that they're highlighted in pink. I would not say that these are our quote-unquote recommended steps, because as I mentioned, step 4 and 5 I think are critical to program adaptation, and step 8 I feel in public health delivery we always need to do staff and capacity training so that they know and understand the intervention, and they also know their specific role in delivery of an intervention. But this is just a way to kind of show you the common steps that were raised from the framework analysis. I also wanted to present a map and show you that really the idea of program adaptation is a kind of more recent phenomenon. You'll see in the 1990s, some of the national organizations of health within the US have launched conferences around the idea of program adaptation. So the National Institute for Child Health and Development, the National Institute for Allergies and Infectious Diseases, and Centers for Substance Abuse Prevention had some conferences that really brought researchers and practitioners together to really understand and talk about the idea of adaptation. And on the bottom, you'll actually see the mapping of the 13 frameworks that we had found in terms of their temporal publication and the dates. And you can kind of see that really in the last 2 decades is where a lot of these frameworks have actually emerged. So hopefully that's helpful to kind of put adaptation in context. As I mentioned, that study was published, and that's attached for you as a handout. The next study that I want to talk about is a systematic review of adaptation of evidence-based public health. And in this systematic review, going beyond the frameworks, we wanted to actually learn what's being done in the field. So these are our research questions. What were the common reasons for adaptations being made? What steps from the self-scoping framework that we identified were being actually reported in these articles that we found? And what outcomes were being measured once they were, or as they are considering program adaptation. This is our process in terms of understanding the articles. We actually were looking at characteristics of the evidence-based interventions, charting the reasons for adaptation, noting the types of modifications based on the Sturman framework that I mentioned before, documenting the adaptation steps, and also documenting implementation outcomes as recommended by Proctor and her colleagues. In terms of our articles, we started off with around 543 articles, and then as we applied our inclusion criteria, we came up with 45 articles, but actually some of them were articles that describe different parts of program adaptation. So there are actually 42 unique programs that we found. And here you could see that it was global in terms of the adapted interventions that we found, some in the US and mostly in the US, but more in other parts of the world as well. And some of the common disease topics focus on HIV/AIDS, mental health, and chronic illnesses such as diabetes. Some of the reasons for adaptations revolved around kind of fitting the new adapted intervention with a new culture, which was 64%, trying to meet a new target population, which was 60%, and maybe implementing in a new community setting, which was 57%. Some of the less common reasons were really around implementation, so improving ease of implementation, improving accessibility to being able to access the program, or condensing the original program. In terms of adaptation frameworks, we were interested in did people cite something that helped them structure their adaptation process, and we did find some articles around 15 or 36% actually reported that they use a pre-existing adaptation framework, and the more common ones were Bernald's ecological validity model, map of the implementation process, and the culture adaptation framework. And the other bullet mentions a couple that were mentioned a few times. In terms of understanding the types of adaptations that were made across the 42 studies, you can see that tailoring and adding elements were two of the most common types of adaptations, but you could also see across German's different classification that there were a lot of studies also making changes in terms of elements, loosening structures, lengthening, substituting some activities or materials, and trying to reorder elements. So we can kind of see that across her taxonomy of adaptations, these are actually also happening in the field. In terms of other adaptations in pink, you can kind of see context adaptations, a lot of changes to fit a new population, 78%, 69% for a new setting. Less changes made to delivery or logistics, so you can see that in the middle with deliverer only 38%. And I think this is important because a lot of times in implementation, we do think about as we move into other settings or other cultures, who's the right person to implement this intervention. If we're going to other cultures or other settings in other countries, we might have to think of task shifting or task sharing. So somebody's role may be shifted to kind of implement a program that is different from the original evidence-based intervention. And then you can see for training and evaluations, those happen at a lower frequency. In terms of the steps in adaptation, we applied the steps that we found, and we actually combine consulting experts and stakeholders together, but you can actually see that a lot of the adaptation steps were actually being implemented across these studies when we actually read through their methods, with the most common ones being conducting your needs assessment, determining the level of adaptation, training staff, preparing your materials, and implementing and evaluating. In terms of implementation outcomes, these are outcomes related to the interventions and what people thought about the intervention. The most common outcome that was measured was acceptability. Secondly, you also have less studies, about half of the studies focusing on fidelity to the original program, the feasibility of implementing the intervention, and then less on adoption of the program, and much less in the area of sustainability, which could be an area of research focus. In terms of general intervention outcomes, you can see the majority of them focus on understanding behavior change, and that isn't surprising because a lot of these focus on behaviors to reduce HIV infections or manage chronic disease such as diabetes. And you could also see the next category as program satisfaction, with a lot less in some of the other areas. Some of the limitations of the study were, of course, delimited by the bibliographical databases that we've selected and the keywords that were used. We also wanted to focus more on public health interventions because that's really some of the focus of my work, and we did not expand it to looking at clinical interventions or kind of psychosocial mental health interventions. So what are some of the lessons learned and the future research that we can suggest from our work to advance adaptation? I do think that being able in future studies and as people are doing adaptations, really to document reasons and the types of changes that they're making is important for us to understand. I think the systematic review study that we presented is, one of the early steps of doing that, but hopefully other people will continue to write about and publish or report on their adaptations, and so that we can understand some of these taxonomies a little bit better. There is some research for the second point that shows that adapted evidence-based interventions are as effective or sometimes more effective than the original evidence-based program. But I think we need to continue to be able to bolster that support or that evidence, and also to really extend the external validity of a lot of the kind of efficacious or effective programs that we have. A lot of times we know that sometimes our developed evidence-based interventions aren't uptaked, and so we have to understand and promote adoption or adaptations, and making sure that those programs are delivered as well in different practice settings. I think our work also helps people think about what are common elements to record as you are doing program adaptation. What are the things that we're studying and that you might want to document, so that we can have more standardization as people are publishing on adaptation. Many of you know about Equator, which is a site that lists a lot of different publication guidelines, and I would say some of the ones are such as STARI and others around implementation have one little bullet or box about adaptation, but no other kind of sub-elements that are important to report. So I think this type of research will get us all more on the same page. And Dave Chambers from the National Cancer Institute here from our National Institute of Health has talked about the idea of having not just clearinghouses for evidence-based interventions, but also promoting the idea of clearinghouses for adapted intervention, so that again, we could have different versions of implemented programs for practitioners to kind of have options to choose and to implement in their practice settings. So I feel like the work that we've done has contributed to understanding and cataloging adaptation frameworks that might be helpful to your work, being able to contribute to the literature about what are key steps and what are processes that people are actually using in the field, and helping us to understand more common types of adaptations happening in practice. And you can see from our work, we reported on that a lot of people made content and context changes overall. In the conclusion, I think that many of us acknowledge that program adaptation will happen in addition to program adoption, that we need to be more systematic in planning our adaptation and also implementing it and reporting it so that others can learn about our process and steps, and the players involved, because as I said before, stakeholder engagement is very important. The idea that you want to be proactive in adaptation, I think, is always important. That doesn't mean that we can't describe more reactive or adaptations that may have been made as we are implementing our programs, but proactive adaptations allow for a lot more stakeholders to kind of vet the changes that you're making to make sure that they are changes that are consistent with the original program or with their logic model and those types of things. And I also feel like this work kind of really presses or emphasizes the need for standardized reporting elements for describing program adaptation. I have a couple slides if you're interested in the reference, and you can see this is the citation for the scoping study if you're interested in it, and you can actually access it under the handouts. I want to acknowledge some resources that I really like in program using evidence-based programs or program adaptation, and you can see those here. The first one was developed through some of my work with our Cancer Research and Control Network, and is actually a training on using evidence-based program. And there is one module on adaptation that you can actually view, and it has a couple of worksheets to kind of help you think through a systematic process. But there are two other resources for you here as well. I want to acknowledge my collaborators. We can't do this work on our own, and our funders, which have been the National Cancer Institute and the CDC, the Centers for Disease Control and Prevention. And one last thing I just wanted to mention is in doing this work, we are trying to advance people's understanding and work in program adaptation. So my colleagues and I at the University of Texas have this National Cancer Institute grant where we are developing an online program to teach you about program adaptation and taking you through a very step process. And we will be fielding this as a trial this summer. If you have interest and meet the eligibility requirements, which are very broad, I invite you to contact me, and I'll be happy to let you know a little bit more about the program if you're interested in really applying some of the things I talked about today. So thank you very much for listening, and I look forward to your questions.
Thank you, Cam, for this excellent presentation. The process of and frameworks for adopting evidence-based interventions for implementation in a new setting is a topic of great relevance to nutrition. So a very brief recap. Cam began her presentation by defining program adaptation and explaining the importance of studying it. Adaptation frameworks have been recently developed to provide guidance on how to select, adapt, and implement evidence-based interventions in order to make a program fit the new context while minimizing changes that can negatively affect its effectiveness. The use of these adaptation frameworks could improve evidence-based intervention acceptability, fit, and effectiveness. Cam and her team conducted the first ever scoping review of adaptation frameworks with the aim of inventory published guidance on the process of program adaptation. They identified 13 adaptation frameworks. This framework shares some commonalities. Cam and her team identified 11 program adaptation steps, 8 of which were common to more than 5 frameworks. Cam also discussed the results of the systematic review of adopted evidence-based intervention. The purpose of this work was to assess adaptations of evidence-based public health interventions in a published literature. In particular, she examined 3 main topics. The first topic was the reason for and the common type of adaptations of evidence-based interventions reported in the literature. She found that the most common reason for adaptations were to adapt them to new culture, new target population, or a new community setting. Less common reasons were to improve ease of implementation or accessibility, and to condense the regional intervention. The second topic was the steps reported in the literature for making adaptations of evidence-based interventions. Of the 42 studies identified, 15 refer to pre-existing frameworks, the most common being ecological validity model, map of the adaptation process, and cultural adaptation frameworks. And lastly, she examined the outcomes assessing evaluation of adapted evidence-based interventions, being the most common the ones pertaining to acceptability. In her work, Cam examined adaptation frameworks and how adaptation occurs in practice, making a relevant contribution to the advancements of implementation research and public health practice. This work consolidates key steps in the process of program adaptation and identifies further research areas to advance adaptation. This is particularly relevant for nutrition, where there's an urgent need to address problems such as stunting and overweight. With this urgency, we might not spend enough time thinking about all that needs to be considered for an adequate scale-up and adaptation of evidence-based intervention. These frameworks provide guidance in this regard, making them valuable resources for those working in implementation and research. Personally, this has been a great learning opportunity. A couple of years ago, I collaborated in adapting a national social and behavior change communication strategy to promote complementary feeding in Mexico. We adapted this intervention to the local context of 3 indigenous groups in Chiapas. We conducted this work informed by formative research with the target groups and in consultation with local experts. Nonetheless, we could certainly have benefited from using an adaptation framework. Cam, thanks again for presenting this work. Let's open the floor to discussion. I will start, if you don't mind, by asking a question myself. Cam, it seems that to me that most adaptations are prompted by changes to the culture or characteristics of the target population. However, adaptations are also important to consider the different organizational capacity and characteristics of the implementation agency. What's your take on this?
Yes, I think that's a very important question. In your society's implementation framework and others, there's a huge box that's called organization, and within that box typically there are aspects of delivery and capacity and resources. I do feel that these frameworks kind of do not speak to that point as much. In the translation or implementation science literature, you will see a lot of focus on organizational capacity and readiness. So I do think for me, I would put understanding organizational delivery, fit, context within that select the intervention step that I mentioned in the adaptation process, where you do need to understand the capacities at your organization, whether it be funding, human resources, volunteer capacity, access issues if you're at multi-site and thinking about delivery. So I think that's a very important question in not only thinking about the population and setting, but also thinking about what context the organization has and how that also gets you to think about the adaptation process, and to me, before that, selecting the right intervention where you can actually deliver that adapted intervention. Good point.
Thank you, Cam. We have a question from David Pelletier. It seems a critical but difficult decision is in defining core versus non-core elements, especially with behavioral interventions. For instance, many aspects of the messages themselves, those frequency, timing, mode of delivery, deliverers, setting of delivery, intensity of training, etc. How can this judgment about core versus non-core issues be made?
This is an excellent question, and this comes as a common question as we talk about doing adaptation as a common barrier, in that this, as you saw from some of our kind of literature and the framework mapping, that this is a relatively newer science in terms of program adaptation. Adopted interventions out there that are publicized on some of the clearinghouses in terms of our quote-unquote evidence-based programs. Some of these clearinghouses help the interventionist or the program planner identify the core elements to some of the things that you were talking about: timing, dose, sequence of delivery, and all of those things. I will say that there are also a set of evidence-based interventions where those core elements are not as well identified, and that's the point you're making. So what are my suggestions in terms of looking at that? One thing that is often a help to that is the step that we talked about is consulting with the experts, and a big key to that, I think, is going back to the original developer. In some of our technical assistance work, we have actually found that the program that one community wanted to implement and make changes, the developers knew that other people's are making adaptation, and so they can actually perhaps suggest to you and ask you what adaptations you want to make and why, and give you feedback on what they would consider core elements. They also may be thinking about this kind of line of implementation and implementation delivery in the field, and some of them that we have gone back to have actually developed some guidance around adaptation. So I would say that's probably one of the more critical thing that you could do is maybe contacting the program developer or going to the package program's website if it's kind of packaged for dissemination that way, to kind of see if there's one, identification of the core elements, and two, if there's adaptation guidance that they're giving as they're seeing that their program is being implemented in the field.
Thank you, Cam. The following question is from Leah Selm. She asked, during this research, were some of the barriers to adaptation explored, or what barriers do you think are the most prevalent?
So I would say one thing that we do well in public health is some of the steps around understanding our community or assessing our community. The point that was just raised by Dr. Pelletier of being able to know what the core elements are and engage people in making changes so that you're not changing the program too much so it becomes not an adapted program, but basically a reinvented program, and then it's really a new program that you actually need to evaluate. So I would say identification of core elements is typically a barrier. Being able, I think, to implement the full adapted program instead of just testing elements of it, I think is also crucial. And that, to me, is quote unquote a pilot or a trial of it. Sometimes you see in these adaptation literature where people will just ask their community about an adapted brochure or adapted message, and it's not kind of the full delivery. And I think that's really helpful to understand. Do implementers know what they need to do? What's the uptake, or the if there's multiple sessions by participants as you kind of deliver the adaptation program, what does everybody think, both in terms of the implementers who are doing the adapted program, and also what do your participants, your community members, how do they receive the adapted program? And to me, that all is very helpful in doing that as a trial, so that you really can address barriers to implementation when you do that trial as your quote pilot, and learn from that, and kind of make your suggested refinements or revisions before going to the fully adapted intervention delivery. Those are some of the different barriers that I think are important to consider, and maybe some ways to address those kind of steps and issues.
Thank you, Cam. The related question was posed by Farrell Lemon. It's, have you come across research where communities were engaged as part of the consulting stakeholders to give their views regarding the interventions selected to be adapted?
Yes. In the second study that we presented, we actually showcased that a lot of the 42 articles that we found, people were engaging in terms of some type of community assessment process. The more common assessment process were focus groups, interviews with community members, and some people use mixed methods in terms of data collection. So I would say a lot of the articles that we found in that study kind of had different ways of engaging the community in an adaptation process. And I'll be happy to share those two articles as references if you're interested in that. The paper that we have that describes some of the elements that I shared today's talk is actually under review. And so as that progresses, I'll hopefully be able to share the final paper as well.
Great. The next questions come from Liner Cherotti. Currently, there's a lot of talk on adaptive programming, which should not only occur as during the planning or design phase, but on real time through the program cycle during implementation, right? So one way of doing this is by using implementation experiences as evidence to inform adaptation. What's your perspective on this?
I like this process as, to me, it's just a step that is in that consulting experts step, and that your whole team is considering the original program, your new context, your new community, and trying to make changes. I will say, though, that you do want to go through a very systematic process of documenting the process, documenting the reasons that you want to make changes and why, and making sure that you understand as much as possible the core elements as you're making these adapted changes. But I do feel that we are really trying to be cognizant of our population, our organization, our context in terms of implementation science. So that type of model gets us to be basically with our feet on the ground and making changes that will kind of increase the implementability and feasibility of delivery.
Thank you, Cam. So you mentioned that sometimes there's a limitation in the sense that we want to test or pilot some of these new elements or components of the intervention, and sometimes we are not able to do that. But this question from Rob Clem, he asked, what have insights from adaptation research taught us about critical components in taking pilot programs to national scale when these programs happen, these pilot tests happen?
I think this is an example of the whole translation process that I presented in the very beginning, that if you are working on an adaptation of a program and you make the changes and then implement and evaluate, that is enough proof or evidence with some positive findings, whatever your level of change is, practice change, behavior change, and changes in your system. You can then think about who are the relevant players to take your program to scale, or natural, sometimes it's national organizations or others, and then taking the evidence that from that adapted interventions, just like we similarly take the evidence from the original evidence-based intervention to the right constituents or decision makers to kind of roll things out at the scale. So I do think we want to use the same framework. We want to be able to describe the program, describe the adaptation, describe positive outcomes, and then thinking about either the maintenance area within your organization, or being able to make the business case within other organizations or systems to scale up your adapted intervention. So that's a really great question, and I would hope that adaptations or adapted interventions also get to go to scale, just like the original evidence-based interventions.
Thank you. Literature comment that the challenge is that in most cases, these experiences are not intentionally monitored, documented, or widely accepted as sufficient evidence. So, on a similar note, Rose Welder comments that she has a question around dissemination, perhaps a 12th step. which is in trying to identify implementation science literature that is rather scarce to potentially impart, due in potential part to the reluctance to publish or share missteps or challenges and what might not work well. Do you know of a repository of public health implementation science research?
Yes, I think this is a great point, and where we have always seen in research the whole idea that published work often focuses on more systematic, rigorous, and sometimes positive findings, and that we could also learn a lot from people reporting their work or processes that may be more preliminary or doesn't have positive findings. And I think it carries into the realm of translation research. I do know that there are a lot of societies and others that have meetings, and I think meetings are a form of gray literature, I think, or actually some research entities call conference meetings great literature. And I would say that is a great example of places where you can learn from others who are implementing evidence-based interventions, doing program adaptations. And so perhaps your meeting in the future, if you have a section or theme on program adaptation. I know I presented at the National Cancer Institute and Academy Health Joint Dissemination and Implementation Research in Health Conference that happens annually in December. And so I would really encourage you to look at maybe sub-themes or attend some of those conferences to maybe get some ideas from people trying to do this implementation or even adoption of evidence-based interventions in the field and some of their struggles. Because I do think you're right that people are unwilling to share or maybe do not have the kind of the venue for sharing their work when they're more in the practice setting and not in the research realm and published literature. So I would encourage societies like yours to maybe have case studies or others that can kind of highlight work in this area. I think that would be great for sharing, and also that conferences kind of focus on implementation, adoption, delivery, and scalability as well, because that's how we learn best from everybody.
Thank you, Cam. Are there any instances where no adaptation of evidence base is required? And this is asked by Helen Delisle.
Yes, this is true too. So in the adaptation or translation model that I presented in the very beginning, as your team or public health practitioners are looking at the available package programs or EBIs out there, you may be able to really sit down with the program with your planning team and look through what does it take to implement the program, the resources, organizational fit, the community fit, and realize that the program as is structured works well, and you don't want me to make any changes. I would say adaptation buys you some time in that you do not have to develop a program de novo. So those of us in program planning and real life public health, that does save us some time. But if you're doing adaptation, that also is a timely process, and sometimes can take a couple of months to a longer time depending on how many adaptations you're making. So if you find that the fit works in terms of the original program, yes, I would say in the early years in the US, in terms of the public health infrastructure and evidence-based program, there was a lot of push from funders to implement evidence-based interventions, particularly some of the HIV interventions as is, without really thinking about program adaptation. So I think that's a common kind of sometimes suggestions, sometimes from funders to kind of use programs as is. And sometimes I think it's suitable because as you look through the intervention and your context in your organization, you may not have to make any changes. And you have just gone through or by-stepped the whole planning process or creating something from scratch, which is always great, I think, in public health.
Thank you, Cam. There's just one last question, and if you can address it quickly, I think it's very interesting and it's related to what you just said. It comes from Anne-Marie Mayer, and she asks, how do you cope with the usually predefined and largely donor-imposed monitoring and evaluation systems if your adaptation changes activities mid-implementation?
Yes, well, I'm hoping that some of the data from this presentation will be helpful to equip you with some of the literature that does say that adaptations do happen in the field, so that you can kind of present that as, you know, a case for doing it. And then I think the better strategy is to kind of focus on the evidence-based programs that you're selecting from and really providing the rationale for what are some of the changes, so the reasons for changes, and what you would like to have changed knowing your audience. So if you have a very structured plan, I think you can kind of quote unquote make the business case to your funders more of why adaptation is needed, but also that you actually have a very systematic plan for making the change, and that would help them kind of understand that you're going through a very systematic and planned process for adaptation. So I hope that's helpful.
Great, thanks. Yes, perhaps one final and concluding remark that you would like to share with us?
Well, I would just like to share that this work is out there for all of you. I hope that you will look through the adaptation frameworks, and if you're considering adaptation, both in terms of advancing adaptation research, maybe use some of the information that we presented today, and maybe work on some of the future research area. But in terms of pragmatism, I'm hoping that you will look at the scoping frameworks and maybe in your next adaptation, or maybe giving TA to folks who are considering adaptation, to get them to kind of go through a documented systematic step in thinking through all of the changes and who to be involved, who are the players, and actually documenting it so that you could share either at conferences or publish your work in both, you know, reports and the published literature. So I'm hoping these are useful references for you. Thank you.
Thank you. Thanks to Dr. Cam Escoffery for joining us today and graciously sharing your research. And thank you all for your insightful questions. We hope that this presentation has been informative and thought-provoking. If you have any other questions or ideas for upcoming webinars, please contact the Society at implementnutrition@gmail.com. Do visit our website to stay up to date on the Society's activities and learn more about implementation science in nutrition and various engagement opportunities available to members. SISN is also active on social media and welcomes your thoughts, comments, and engagement through their Twitter and LinkedIn page. Once you leave today's webinar, you will receive a brief survey on the webinar, and we would appreciate if you would take a few moments to provide your feedback. You will also receive a follow-up email in a few weeks with a link of today's webinar recording and URL to the PDF of the slides. On behalf of SISN, thank you for joining us today and have a great rest of your day.